Welcome to the USMLE Step 3 series, strategy series, where I will try to help you manage your understanding of the questions, manage your time, and stay in control during the exam. I'm Dr. Sarah Ahmed, a practicing hospitalist, and have a large passion about teaching and educating. In this series, we'll be helping you develop strategy to manage the exam. And it's not about the information, it's about how you address the different elements of the exam, the time, anxiety, the software, understanding the question, and trying to go through it in an organized manner. So in this first episode, we'll try to go over understanding the question step. And people might ask me, what do you mean understanding? We do understand. It's just we don't have time to go over everything. Yes, you don't have time. I agree. But from my experience, and by the way, I was one of the 1%ers in terms of performance in the USMLE exams in general. I scored consistently above the 97th percentile. And in one of the exams, I did above the 99th percentile. So I know how to do well in exam situations. That doesn't mean I know the most information. Because as you will come to know, the exam is not about information. It's about management. Okay? It's about managing your resources. Your knowledge is one of them, the information, time, anxiety, planning, all this comes. It's a management issue. So the more or the better strategy you have, the better your performance will be. Okay, so this first episode is about what I call the hidden agenda. You need to sift across the question to come up with the agenda behind it. What are they asking? So it's about mastering the art of decoding USMLE Step 3 questions by understanding what examiners are really testing. This guide reveals the systematic approach to analyzing question stems and identifying the critical decision points that lead to correct answers. Now, there is a core principle that everybody needs to know about this exam, specifically Step 3. They are not testing how much you know. The knowledge base, the fundamentals were tested in Step 1 and Step 2. These Step 1 and Step 2, CK, are mostly about knowledge and information. Here, they are testing how you think, the decisions you make. And the more you think in a way that's parallel to real life, the better you do. Okay? This exam is about testing you or preparing you to work as a generalist in the American healthcare system. That's the idea behind the Step 3. Every STEM has what I call hidden agenda. And your job is to decode that instantly. And to decode it, you go through steps. I divided these steps into 5 steps. The step is long, and that's on purpose, by the way. Life is never clean. And the patients that come to the emergency room or they come to your attention is never easy, straightforward situation. It's usually there is a lot of fluff and noise around their stories. You need to sift across this and come up with what really matters at this moment. Okay. This sifting across the information or the fluff is called the decision-making process. The neater and the cleaner and the better your decision-making pathway, the better you are at handling the exam. So to start with, as an introduction to this strategy of the revealing the hidden agenda, you have 5 things that you need to look for. Patient stability status, the clinical trigger detail, we'll talk about that, relevant facts versus noise or fluff, timeline of presentation, and the category of clinical decision, or what actually the question is asking you to decide. This systematic approach transforms overwhelming clinical vignettes into clear, actionable pathways. The examiners deliberately embed distractors and irrelevant information to test your ability to prioritize like a clinician's under pressure. That's the idea. That's how step 3 works. It's testing your ability to function just like in real life as a generalist, not a specialist, a generalist. And let me tell you what is the difference between a specialist and a generalist. The generalist sifts across a lot of noise. The patient in its raw form coming to you, and you are the first to see that. That's a generalist. Okay? So the cleaner and more neat your decision-making process, the better generalist provider you are. Okay, so let's go over the 5 elements you must extract in every step 3 question, in every patient, basically. These 5 elements form the foundation of clinical reasoning on step 3. Master this extraction process, and you will approach every question with confidence and clarity. As I said, stability assessment. Is the patient dying right now? Okay. Basically, is the patient stable or unstable? First, decision. Number 2, clinical trigger. And clinical trigger can be confused with other terms like buzzwords or patterns. We will clarify this area. Clinical trigger is the one detail that determines the answer. That's a clinical trigger. Find it. Look for it. Number 3, ignore the fluff or the noise. 70% of STEM content is irrelevant noise, believe it or not. They will give you a STEM that you need to scroll up and down to finish it. Just a few, less than 30% of this information or this STEM is necessary to answer the question. Timeline. Acute versus subacute versus chronic. Categorize your patient's presentation. Does the history spans minutes to hours, days to weeks, or weeks to months? This is called the timeline. And of course, along this timeline, you have progress, you have a progression and changes that happened along it. But you are interested to see whether it's acute, subacute, or chronic. And there is some element called hyperacute, that's minutes. Then the 5th part is, what is the category? And we'll talk about that. What do we mean by category? What type of decision is being tested? Are we testing management? Are we testing diagnosis? What are we testing? Next step, whatever. Okay. Number 1, from the 5 elements in trying to reveal the hidden agenda is stability. Before you read anything else, scan the vital signs and mental status. These are the 2 things that will decide the condition of your patient. This is how you decide stability. Vital signs and mental status, because instability will show itself here. Okay? This single assessment determines whether you stabilize immediately or proceed with diagnostic evaluation. because you have a couple of actions to do in every patient. Either you resuscitate now, act on the patient now to stabilize, or try to come up with a diagnosis, and for that you need some diagnostic workup. So we are in the first fork, okay? The first decision point. If the patient is stable, you can proceed with doing different tests and other interventions. But if the patient is unstable, this is your priority. You can't move beyond that unless the patient is stabilized. Okay? So the critical parameters to check are blood pressure. We are looking for signs of hypotension or shock, heart rate, tachycardia, or bradycardia. Respiratory rate. Is the patient tachypneic? Are they in distress? Autosaturation. Is the patient hypoxic, meaning autosaturation less than 90%? Temperature. Another vital sign parameter. Mental status. And here they do write it as AMS, altered mental status. And it's a sign of hypoperfusion to the brain. Of course, we are talking about acute changes in mental status. We are not talking about long-standing dementia. We are talking about something noticed by the family over the past few hours or few minutes. Okay, the golden rule about the stability element. If the patient is unstable, stabilization beats diagnostics every time. If the patient is unstable based on all these parameters or any of these parameters, and you chose to do a CT scan, that's wrong. No imaging, no labs, no consultations until the patient is stable. Okay? As I said, these are the parameters that you look for, and these are the vital signs and the mental status. Number 2, and this is very interesting area. Identify the clinical trigger. What or 2 key details that will derive what to do next. Let's assume we identify the patient as stable. The patient stable. Now we can move to the next step. The clinical trigger is the one detail that determines the correct answer. It's not always a buzzword. Don't confuse clinical trigger with buzzword. Okay, buzzwords are known words that are linked to specific diagnosis. When you see it, the diagnosis is known. Tearing chest pain, I'm talking about aortic dissection, stuff like that. These are buzzwords. But here, it's a clinical trigger. It's a detail. It's a one detail in the clinical presentation that will determine the next action. It's the clue that forces an action. This is where most students waste time. They read every word equally when they should be hunting for the trigger. When you are scanning the stem, and I can't stress this further, you can't read every word. No, you have to scan. And you need to learn how to scan the stem. Okay? Classic trigger examples. And by the way, the clinical trigger could be a buzzword, but it's not the same. Not always a buzzword. Tearing chest pain, the trigger aortic dissection, the action, you need to do beta blockers, then CT angio of the chest. Okay? Nuchal rigidity, the trigger is meningitis. Nuchal rigidity, meningitis. Okay, action, lumbar puncture, antibiotics immediately. Pregnant plus abdominal pain, trigger ectopic pregnancy risk. Action, beta HCG level urgently. Fever, hypotension, confusion, it triggers sepsis syndrome. This is sepsis. Action, sepsis bundle action, cultures, fluids, antibiotics, and so on. Another example, sudden severe headache. the trigger is, or it triggers subarachnoid hemorrhage thinking. I will think about subarachnoid hemorrhage immediately when I see this term. Okay, the action, CT head immediately, no contrast needed. The trigger may be a single word, specific vital sign, a timeline descriptor, or a combination. So it can be any of these. The idea behind it is it clues you to a specific diagnosis. And that specific diagnosis usually requires immediate action. It will decide what to do next. That's why it's called clinical trigger. If I see any of these terms, I will immediately take action towards mitigating the situation or managing it. Okay? Train yourself to identify it within the first 10 seconds of reading the stem. I know maybe people will panic when they see these second things, but with practice, you can do it. Now, the third element in trying to understand or figure out the stem is to ignore the fluff. Remember, 70% of the stem is noise or fluff. USMLE writers deliberately pad stems with irrelevant detail to test your clinical prioritization. They include hobbies, family information, job descriptions, personal habits, childhood story, and tangential medical details that have zero bearing on the correct answer. You only need, there are certain things that are vital to know. The age, the setting, is it the ER, the inpatient, the clinic? This will give you a clue about the urgency of the situation. Okay, the vitals. And of course, we talked about vitals as a big part on determining stability, which is the first step. Symptom pattern. The patterns will come at some point when we are talking about strategies to handle MCQs. Pattern recognition is one of the strategies to get to the diagnosis. Okay? And it's used both in the exam and in real life. We also, as practicing physicians, use pattern recognition. So if you have a specific pattern, then that helps you sift across this noise. Timeline, and we mentioned that timeline is important. Is it acute, subacute, or chronic, or even hyperacute? And the trigger, which is the one high-yield clue. Okay? When somebody comes to you and they give you a stem that's half a page, and they stated that tearing chest pain, and he is a 56-year-old male smoker, diabetic or hypertensive, and they gave you this statement or this term of tearing chest pain, your antenna should be high and you should be running, trying to reduce his blood pressure using IV beta blockers and trying to confirm whether you are dealing with aortic dissection or not, which is CTA, CT angio may be the best test to do that. Okay, so look for this information at least out of the stem and try to ignore the rest. The age, the setting, the vitals, the symptom pattern, the timeline, and the trigger, the clinical trigger. Everything else is designed to slow you down and exhaust cognitive bandwidth. Reading every word equally is a time management disaster. You can't do that. You can't go over 40 plus questions within 1 hour by reading the whole stem. No, you need to learn how to scan. Scan looking for this information. This is what you need to be looking for. So your working memory can hold 4 to 7 pieces of information. Don't waste slots on the patient's occupation or family vacation plans. Reserve mental space for clinically actionable data only. And these are the ones that you need to be looking for. Develop the skill of selective attention. As you read, actively categorize information as clinically relevant or noise. Okay? This becomes automatic with practice and dramatically improves your speed and accuracy. So now we go for the fourth element. Determine the timeline, acute versus subacute versus chronic. There are other terms. Hyperacute, for example, is one of the terms that can be used, but these are the commonly used terms. The timeline tells you that, or what kind of decision they want. It determines urgency, appropriate diagnostic approach, and whether stabilization or systematic workup is indicated. For example, acute means minutes to hours. That's the timeline for the presentation of the patient. Action, stabilization plus emergent management. Any condition that pushes people to come to the ER or to the medical attention within minutes to hours is acute. And acute conditions usually require acute actions. Okay, emergent actions, quick actions. Example, STEMI, pulmonary embolism, stroke, septic shock, acute abdomen. Remember, in medicine, we have a category of conditions that are time sensitive in terms of management. The more you delay action, the worse the outcome. One of them is stroke, sepsis, acute MI, STEMI or otherwise, and so on. These time-sensitive conditions require immediate action, and they have protocols in place to follow. So be mindful of that. Know these things. The mindset, life-threatening until proven otherwise. Imaging and treatment happen simultaneously. You don't delay action. You don't delay therapies waiting for results. That's usually very bad in acute problems. Usually simultaneously, you intervene by providing the life-saving or muscle-saving or brain-saving interventions while trying to work up the patient in other ways. Okay? Subacute, meaning days to weeks, the action, systematic diagnostic evaluation. Now you have time. The patient actually stayed at home for some time before coming to you. This means it's kind of and somehow indolent timeline. And this means you have some time to try to reach to a diagnosis. Examples, unintentional weight loss, new anemia, persistent headache, chronic cough, something like that. The mindset, orderly workup. You have time to think about what's happening here. Okay? Get more information through history taking, physical exam, and other workup. Do imaging, do labs, do whatever you need to do to reach a diagnosis. So if it's a subacute presentation, you have some time to think. Start with the least invasive and the highest yield tests. And this is in itself an art. People don't jump to the most expensive test in every workup. No. Now, chronic conditions, these are usually months to years or lifelong. Long-term management optimization, that's the action usually required out of this. Okay? Like diabetes medication titration, hypertension control, heart failure therapy adjustments, and so on. That's usually what the question is trying to ask you to do. Management adjustments or optimization. The mindset, incremental changes, evidence-based protocols, guide decisions. Okay? So these are the three, how the timeline can impact your decision-making process. Acute, intervene now. Stabilize, and do therapeutic intervention at the same time. It's usually an emergency situation. Subacute has been there for days to weeks. You have time to reach a diagnosis and do some diagnostic workup. Chronic, usually management optimization or treatment adjustments. Timeline errors are common. Students treat subacute presentations as emergencies, over-testing, over-treating, or miss acute emergencies by being too methodical. You don't have that leisure or that kind of time in the acute situation. Let the timeline guide the pace and intensity of your intervention. Okay, the fifth part. Now we need to identify the question category. What exactly is the question asking? Every question boils down to one of these 6 categories. Once you know the category, the answer becomes obvious because each category has its own decision framework. What are these categories? Stabilization, and we said this is linked to unstable vital signs or altered mental status together with acute timeline. You look for a stabilization need here in these kind of questions. ABCs take priority. ABCs, this is airway, breathing, circulation. Common interventions, oxygen, IV access, fluid pressors, airway management. Examples, hypotensive patient with altered mental status. Here, the question is asking you to stabilize the patient. Treatment. Diagnosis is established. Select the correct therapy based on guidelines and contraindications. Example, confirmed community-acquired pneumonia. Which antibiotic? That's a valid question. They can ask you that. Avoiding harm. The safest next step. Multiple options seem reasonable. Choose the one with the lowest risk of harm or complications. Example, pregnant patient with suspected appendicitis, ultrasound before CT. That's safer. It's safer to do ultrasound in a pregnant woman than to go ahead and do CT, despite the fact that CT is a higher quality test or a superior test to ultrasound in regular times or in regular non-pregnant patients in the setting of appendicitis. Diagnosis, that could be a valid category, okay? And patient is stable, but diagnosis unknown. Choose the most appropriate next diagnostic test. Consider sensitivity, specificity, invasiveness, and risk. Examples, chest pain with normal EKG, what imaging? Monitoring. Patient is on treatment. What parameters do you follow? Examples, patient started on ACE inhibitors. Check creatinine and potassium in 1 to 2 weeks. That could be one of the things. Monitoring either in the hospital or outside the hospital chronically. ACE inhibitors have the tendency to affect potassium level and affect the kidney function sometimes in some patients. So that's what you need to monitor. And the 6th category is public health / systems-based practice. These are kind of a general category that's related to patient safety, ethical issues, public health related issues like questions about reporting, consent, quality improvement, healthcare systems. Example, patient with suspected elder abuse is mandatory reporting, for example. So these are the 6 categories in general that you will be asked about in step 3. Now, we decided that this is what to do about how to think. We decided the 5 elements that you need to look for in every question stem. And in the CCS, by the way, CCS is also part of we are talking both. What I'm trying to give you is a framework that we use in real life. In real life, we look for stability, we look for the clinical triggers, we look for patterns, we look for what should we do next, and these clinical triggers actually are the way to do or decide that. If somebody is with STEMI, you don't do anything besides stabilize the patient and alert start managing the patient immediately and alert the cath lab. Don't think of any other diagnostic tests. It's action, right? So how to use it? This is your mental checklist for every step 3 question. Execute this process in 15 to 20 seconds before looking at answer choices. Usually, if you can go over your 5-step or 6-step checklist before you look at the choices, that will be the best, because then you will know what to choose immediately. You will not waste time. You will look for the correct answer rather than read everyone and try to see if it's correct or not. This systematic approach eliminates confusion and dramatically improves accuracy. Scroll to vitals first, stable versus unstable. This determines everything that follows. If unstable, stabilization is likely the answer. Number 2, find the clinical trigger. What is the one detail that makes this question or this case unique? This is your diagnostic anchor or action trigger. Number 3, discard fluff actively. Cross out or mentally ignore hobbies, job description, and irrelevant personal history. Preserve cognitive bandwidth for what's important. Remember, it's 4 to 7 data points that can be kept in your brain or within your cognitive or memory. Preserve that. Identify timeline, minutes, days, or months. This tells you the urgency and type of approach, emergent versus systematic versus chronic management. Then determine the question category: stabilization, diagnosis, treatment, monitoring, harm avoidance, public health. Each has its own logic tree. Then we come to the choice, and then we'll choose the safest, most appropriate next step. Apply the decision framework for the category. When in doubt, choose the option that provides the most information with the least risk. This is exactly how the NBME designs step 3. They are testing your ability to prioritize, recognize patterns, and make safe clinical decisions under time pressure. Master this framework, and you are thinking like the test writers. Let's take some practice questions. We have 5 questions. We'll go over them quickly. Each question illustrates a hidden agenda explained in lesson 1. Work through these systematically using the 5-element framework. Identify stability, trigger, timeline, category before looking at the answer choices. How to use these cases? Read the STEM and apply the 5-element extraction. Write down your assessment before reading answers, and then compare your reasoning to the breakdown provided, and focus on the process, not just getting the answer right. The process is more important. That's what you are trying to get out of this episode, is to develop a clear, organized, structured process. Any process has steps. So that's what we are looking for here. Each okay. Question 1, stability check and trigger. 72-year-old man presents with shortness of breath. Vitals, blood pressure 78/40, heart rate 132, respiratory rate 30, and auto saturation 84% on room air. He is pale, confused, and diaphoretic. Lung exam shows crackles. ECG shows ST elevation in leads V2 to V4. What is the next best step? Please, out of this, look for stability and clinical triggers. Is the patient stable or not? Look at the vitals. Look at the mental status. All are messed up. He is unstable. Okay? Lung exam is one of the objective things we looked for. He has crackles, but the ECG is the most telling. He has ST elevation V2 to V4, indicative of STEMI. Okay? Answer choices: order troponin, give aspirin and obtain cardiology consult, CT angio of the chest, start IV fluids slowly and give diuretics, transport immediately to cath lab. Look at the clinical trigger. Before I reveal the answer, look at the stability and clinical triggers, and this will decide your next action. Okay, let's look at that. Stability assessment, unstable, definitely. Low blood pressure in cardiogenic shock, altered mental status, severe hypoxia, tachypnea, all kinds, and tachycardia, all indicative of instability. The clinical trigger here is ST elevation in V2 to V4, anterior STEMI. That's what will drive your action, the instability and the clinical trigger. Timeline, hyperacute. Minutes. Every second of myocardial ischemia matters. This is one of the time-sensitive conditions that you need to act immediately. Question category, emergent management and stabilization. Yes. So the correct answer out of the 5 choices, and I hope you made that choice, transport immediately to cath lab. This is how you save the heart muscle. Okay. Transport immediately to cath lab. Troponin is irrelevant when you have a STEMI on ECG. You don't really need troponin to do what? Your diagnosis is already confirmed. You have ST elevation myocardial infarction. Okay? Troponin is a lab test that will take time, and waiting for it or doing it will not add anything to this situation. CT is dangerous and delays reperfusion. And remember, the patient is already unstable. You can't send the patient for tests like a CT scan when they are not stable. The patient needs emergent percutaneous coronary intervention, PCI. So the conclusion is stability decides everything. Unstable STEMI goes right or straight to cath lab. Door to balloon time is critical. This is maybe a dramatic case, but it explains what I mean by stability and clinical trigger. Why other answers are wrong? Ordering troponin wastes time. Diagnosis already confirmed by ECG. Aspirin alone is insufficient for cardiogenic shock. You have a STEMI with cardiogenic shock, you need to act quickly. Aspirin alone, okay. The chest would delay definitive treatment and the patient is too unstable to lie flat in a scanner. IV fluids with diuretics is contradictory and doesn't address the ischemia, which is the problem here. This patient is going through active ischemia to his heart muscle, and what you need to do is to save the heart muscle from being infarcted, and it's a time-sensitive situation. Okay, let's take another example. Clinical trigger overrides buzzwords, and here you might understand the difference. As I said, buzzwords could be the clinical trigger, but clinical trigger is more important than buzzwords at times. 32-year-old woman presents with acute severe abdominal pain. Her last menstrual period was 7 weeks ago. BP is 110/70, heart rate 112, ultrasound is not available immediately. Next best step. The answer choices: CT abdomen with contrast, pelvic ultrasound in 4 hours, beta HCG level, diagnostic laparoscopy, NSAIDs, and outpatient follow-up. Hidden agenda breakdown. Stability, borderline stable. She's mildly tachycardic, but our blood pressure is maintained. Trigger, reproductive age woman plus abdominal pain plus missed period. Rule out ectopic pregnancy. Category, rule out emergency. It's a diagnostic category, but it's an emergency at the same time. The correct answer is beta HCG level now. Ultrasound may follow, but you must confirm pregnancy first. CT abdomen with contrast is contraindicated in potential pregnancy. Avoid harm. Waiting 4 hours for an ultrasound is dangerous if this is a ruptured ectopic. Clinical reasoning. The combination of acute abdominal pain and amenorrhea in women of reproductive age mandates immediate pregnancy testing. Beta HCG is rapid, definitive for pregnancy detection, and guides all subsequent management. If positive, urgent ultrasound follows to determine location, whether it's intrauterine or ectopic. If negative, you can proceed with other diagnostic considerations. Diagnostic laparoscopy without confirming pregnancy first is premature and potentially harmful. You can't send the patient to the OR for diagnostic laparoscopy when you don't know whether she's pregnant or not. That's premature. Question 3. Ignore fluff, focus on pattern. 45-year-old postal worker with 20 years smoking history presents with chest discomfort described as sharp. He recently returned from a stressful work trip. Vitals: HR 120, BP 128/80, SpO2 to saturation 90%, clear lungs, D-dimer is pending. Next best step. Start aspirin, CT pulmonary angio, reassurance and discharge, order stress test, wait for D-dimer. The hidden agenda breakdown. Ignore the fluff. Postal worker, stressful work trip, these are distractors designed to make you think anxiety or musculoskeletal pain. Focus on the pattern. Pleuritic, sharp chest pain. Hypoxia. O2 saturation 90% is not normal, by the way, in a normal person. Normal healthy lungs give you usually 94% or more, or even 96% or more. Tachycardia. Risk factor, smoking, recent trouble. You see where we are going? Trigger. This constellation, pulmonary embolism until proven otherwise. Timeline, acute, hours. Category, emergent diagnosis. Here, you want to diagnose whether this is PE or not. Okay? The patient is fairly stable and you have this pattern or a lot of diagnostic triggers, clinical triggers that point towards a specific diagnosis. I understand PE is one of the serious problems that we would like to look for when somebody is presenting with chest pain, but you have time. The patient is fairly stable. The correct answer is B, CT pulmonary angiography, which is considered maybe the gold standard. The gold standard is actual angiography, but CT angiography comes close second to that. Stress test is dangerous in acute PE. It could precipitate cardiovascular collapse. Waiting for D-dimer is inappropriate when clinical suspicion is moderate to high. D-dimer has high sensitivity but low specificity. It's not for diagnosis. It's for when you have an intermediate risk, you want to sway it either this way or that way. So you resort to this high sensitivity testing like D-dimer, as it can rule out rather than rule in. Okay. Wouldn't rule out PE in this Wells score category. CT angio, CT pulmonary angio, is the gold standard diagnostic test. Confirming the learning point. Don't let psychosocial details distract from objective physiologic abnormalities, hypoxia, tachycardia, pleuritic pain, risk factors. PE workup immediately. The job stress is irrelevant noise. Okay. Question 4. Timeline identifies category. 34-year-old man presents with a headache for 3 months, gradually worsening. Neurologic exam is normal, vitals is stable. What's the next step? Just look at the timeline. It's chronic or subacute. The answer choices, as we said, chronic subacute, you have time. CT head without contrast, MRI brain with contrast, lumbar puncture, IV steroids, non-steroidals, and follow-up. Hidden agenda breakdown. Timeline assessment. 3 months. Chronic to subacute. Presentation not emergent. Stable vitals, normal neuro exam, safe for diagnostic imaging. Red flags, progressive headache over months, concerning for a mass lesion, increased intracranial pressure. Number 4, imaging choice. So that's what I'm thinking right now. This guy is having progressive headache, and I need to look into that brain. Doing imaging is the next step. MRI is superior to CT for mass lesions, posterior fossa, and subtle abnormalities. So the correct answer is B, MRI brain with contrast. CT head is reasonable, but MRI is superior for evaluating chronic progressive headaches. Contrast enhancement helps identify tumors, inflammatory lesions, and vascular abnormalities. Lumbar puncture before imaging in a patient with potential mass lesion risks herniation. IV steroids are premature without a diagnosis. Non-steroidals and follow-up miss the potentially serious underlying cause. Timeline principle. The 3 months duration tells you this is not an emergency requiring immediate CT. You have time for the superior diagnostic test, MRI. Contrast the decision you would make for worst headache of life, acute immediate CT for arachnoid hemorrhage, versus progressive headaches over months, which is subacute, then systematic evaluation with MRI. The last question that we'll go through now is identify the question category, and I think that's important. 64-year-old man with diabetes presents for routine follow-up. A1C increased from 8.1% to 9.4% over 6 months. He feels well, vitals stable, no acute concerns. Next best step. The answer choices, remember this is optimization of therapy. Chronic condition, you have time, no immediate needs, but long-term optimization of therapy. The answer choices are check urine ketones, start insulin immediately, increase dose or add second oral agent, order CT abdomen, hospital admission. Hidden agenda breakdown. Stability, completely stable, routine outpatient visit. Timeline, chronic condition, diabetes with 6 months trend. Category, chronic disease management, medication adjustment. No emergency, patient feels well, no acute symptoms. Decision type, this is a med titration question. So the correct answer, identify or intensify diabetes therapy. Increase current medication dose or add a second oral agent per ADA guidelines. A1C of 9.4 is above goal, but not a diabetic emergency. No need for urine ketones, patients not symptomatic for DKA. Insulin is premature. Step up oral agents first. CT abdomen is irrelevant. Hospital admission is completely inappropriate for asymptomatic hyperglycemia. Category recognition. This question tests whether you understand the difference between acute management, DKA, HHS, and chronic glycemic control optimization. The 6 months timeline and routine visit context make this clearly a chronic management scenario. Apply evidence-based stepped approach to diabetes therapy intensification. Summary of the lesson. You have now seen all 5 framework elements in action across real step 3 style questions. Master this systematic approach and you will decode question stems with speed and confidence, focusing your cognitive energy on clinical decision making rather than parsing irrelevant details. I know this lesson was too long, almost an hour, but it's very important. If you can master these 5 element strategy, you are bold in answering step 3 questions. Okay? And you can apply this strategy actually to both MCQs, which they give you choices, and you can apply it in a maybe a little bit modifiable way to CCS as well, because it's the same type of thinking. See you in the next video.